David Vedder is famously known as the boy in the bubble. He was born in 1971 and diagnosed with severe combined immunodeficiency, also known as SCID. At that time, a bone marrow transplant from an exact donor match was the only cure for SCID. However, there was no match available in David's family. Due to this, David had to live within a bubble, which allowed him to live for 12 years. David's mother, Carol Ann, and science have stated that because of David's story, many children with SCID have been diagnosed early, received bone marrow transplants, and now live healthy lives. I have attached a link to a YouTube video regarding David's story. The topic of our presentation is diseases in purine metabolism. The first one being addressed is severe combined immunodeficiency. Severe combined immunodeficiency is a primary immune deficiency, also known as PIDD. The defining characteristic is usually a severe defect in the T lymphocyte system. It sometimes includes a defect in the B lymphocyte system. The role of the T cells include directly killing infected host cells, activating other immune cells, producing cytokines, and regulating the immune response. B cells are responsible for mediating the production of antigen-specific immunoglobulin directed against invasive pathogens. This immunodeficiency typically prevents in infancy. It results in a weak immune system that is unable to fight off even mild infections. It is the most serious PIDD. If SCID is not treated, death often occurs. There are about 20 different defects in genes that can result in SCID. Each individual defect is considered a type. Most types of SCID are classified as typical SCID, which is characterized by low or no T cells and a non-functional immune system. There are two exceptions to typical SCID, leaky SCID and Omenn syndrome. In leaky SCID, there is a defect in a gene, yet allows for a normal or elevated T cell count, which ends up harming the immune system. Omenn syndrome has defects in genes, thus causing high numbers of non-working T cells. It also has a lack of B cells, which results in a faulty immune system. Treatment will vary depending on the SCID type, so it is crucial to know what kind is affecting the child. X-linked SCID is the most common form. Of all the cases, about 40% are X-linked, but it generally only will affect males. Girls can be carriers, however they will not be affected. In this form of SCID, there are mutations in the IL-2RG gene. This gene tells the cells to make proteins that help immune cells to grow. Without them, infections will be contracted quickly. B cells are non-functional in this form, and there is a very low count of T cells. At birth, a child with SCID may appear healthy despite being extremely vulnerable to germs. Symptoms generally begin within the first year of a child's life. However, these will vary a bit with each case. These may include frequent life-threatening infections that are hard to treat and generally do not respond to medications, recurrent respiratory infections, yeast infections, skin rashes and infections, and failure to grow and gain weight at a normal pace. A diagnosis of severe combined immunodeficiency is usually based on a complete medical history, physical examination, and multiple blood tests. The majority of SCID cases are now diagnosed based on newborn screenings. This screening is performed utilizing the dried spot from newborn screening cards and measure levels of T receptor excision circles. A low TREC test means the infant has low numbers of lymphocytes in their blood at the time of the test. Confirmation must be made with additional testing prior to diagnosing. A complete blood count along with lymphocyte subset testing may show low levels of B, T, and/or NK cells. For certain forms of SCID, genetic testing is available. A bone marrow transplant is considered the best treatment for SCID. This is usually completed by the age of 3 months. The type of severe combined immunodeficiency, as well as a bone marrow match is available to the patient, are two important factors when it comes to treatment. While waiting for this to happen, it is crucial to avoid sick contacts and to avoid breastfeeding to prevent transmission of infections that can make the transplant less successful. If infections occur, they must be treated aggressively. St. Jude has founded gene therapy that cures patients with X-linked SCID. It involves collecting a patient's bone marrow, using a virus as a vector to insert a correct copy of the IL-2RG gene into the genome of the patient's blood stem cell. The cells were frozen and underwent testing. Prior to receiving the gene-corrected blood stem cells, the infants received 2 days of a low-dose busulfan, which is a chemotherapy commonly used in bone marrow transplants to make space in the marrow for the donor stem cells to grow. 3 months after treatment, gene-corrected immune cells were present in the blood of all but one patient, who did require a second dose of gene therapy. All patients are developing normally, and none have developed a life-threatening infection since receiving gene therapy. This is still new research, so it is too soon for them to know if there will be any long-term side effects. For patients who have adenosine deaminase SCID, enzyme replacement therapy is available. A missing enzyme is injected regularly into the patient. This is a treatment, but not a cure. This injection is done at least weekly and allows the immune system to function. As a child gets older, this may not be as effective over time, so other treatments will be considered.
To understand SID and the Lesch NYHAN syndrome, we have to understand the purine pathway. The purine pathway is when we take adenine, hypoxanthine, and guanine and then turn them into their monophosphate forms, which can then turn into their deoxyribose forms, which can be incorporated into the DNA. So hypoxanthine and guanine both use the same enzyme, HGPRT, which is hypoxanthine guanine phosphoribosyl transferase, to take PRPP, or phosphoribosyl pyrophosphate, into their monophosphate forms. On the adenine side, there's APRT enzyme, or adenine phosphoribosyl transferase, which turns it into the monophosphate form. And we'll touch more on the HGPRT when we talk about Lesch NYHAN syndrome. To understand more of the importance of the purine synthesis pathway, let's look at the de novo, or a new, purine synthesis, in which we have a 5-carbon phosphate sugar, which is the backbone of RNA and DNA, and we're turning that into IMP, or inosine monophosphate. This is done through crucial additions through THF, which is oxaline, glutamine, aspartate, and then also glycine. And glycine is what separates the purine synthesis de novo pathway and the pyrimidine de novo synthesis pathway. And so from IMP, we can then dehydrogenase it into GMP and AMP. And this is all regulated by several enzymes. But this is very critical for rapidly dividing cells, which the two most common and prolific are cancer cells and immune cells. Thus, you see, if there is a damage in the system, it can be very problematic. So, talking about SID and the purine pathway, we have adenosine monophosphate getting turned into adenosine and then getting deaminated into inosine. And inosine can then turn into hypoxanthine and guanine, the other purine bases, and then proceed into other parts of the pathway. But let's focus on the adenosine to inosine. This is done by the critical enzyme adenosine deaminase. So in SID and this purine pathway, this adenosine deaminase enzyme is not working correctly, and that leads to adenosine deaminase deficiency. And this ADD causes an excess amount of adenosine, and adenosine is toxic to B and T cells, which are the two hands of the adaptive immune system. And the only way to treat this is through bone marrow. transplant.
For the next purine metabolic pathway disease that we are going to discuss is Lesch Nyhan syndrome. Now, you may be wondering, what is Lesch Nyhan syndrome? It is a rare genetic disorder that is characterized by behavioral and neurological abnormalities alongside the overproduction of uric acid in the body, which we'll get a little more into later on. It occurs exclusively within males, but females can be carriers of the disorder. They just simply will not actually have symptoms of the disorder. Lesch Nyhan syndrome is caused by mutations in the HPRT1 gene and is inherited in an X-linked recessive manner. Next, we are going to discuss the symptoms of Lesch Nyhan syndrome. Due to the fact that Lesch Nyhan syndrome impacts so many different parts of the body, such as cognitive, neurological, behavioral, it has a number of symptoms that span across all boards of the body. Shown in the table here, you will see that there are 3 categories. Your top category is the more commonly occurring symptoms that are reported amongst patients. You have your middle category that is not as many patients report them, but they are reported as symptoms of Lesch Nyhan. And then the bottom category is less than 30% report these symptoms, but they are present in some cases. Very common symptoms you will see with Lesch Nyhan that are almost 99% of cases is gout. You'll also see hyperuricemia, which is high blood uric acid levels. You'll also see intellectual disabilities present. Other things are blood in the urine, which is not as common but still common. You'll also see difficulty articulating speech, decreased muscle tone, throwing up. There are a number of symptoms that arise with Lesch Nyhan syndrome, in which we will discuss further in the treatment portion of this presentation. When discussing the diagnosis process of Lesch Nyhan syndrome, you'll find that many healthcare providers have to utilize a combination of factors due to the fact that this syndrome is so rare. Healthcare providers will oftentimes use patients' medical history, symptoms, physical exam, and lab results to come to a conclusion for their diagnosis. In modern day medicine, there are approximately 74 tests that can be performed to diagnose Lesch Nyhan. There's enzyme assays, there are sequence analyses of select exons, there's trying to detect mutations. We're going to go through the steps of a diagnosis process for Lesch Nyhan in the next slide. When it comes to diagnosing Lesch Nyhan syndrome, you'll note that there are 4 major categories of testing and diagnosis processes that occur. The first one is a clinical diagnosis. This comes from the initial physical exam when observing the patient. It is oftentimes suspected in males that display developmental delay and have neurological, cognitive, or behavioral disturbances. A telltale sign of Lesch Nyhan syndrome is the behavioral disturbance of the impulse to chew on nails, meaning males oftentimes will continuously chew on their nails with the inability to control the habit. Moving on into preliminary testing, there is a calculation that is performed. It's called the urate to creatinine ratio, and this is a reliable way to measure uric acid overproduction. When the ratio calculation is found to be above 2, this is when you're noting that there is a higher possibility of Lesch-Nyhan syndrome occurring due to the higher level than 2. Other notable tests that healthcare providers also do within preliminary testing is monitoring for hyperuricemia, which is uric acid buildup in the blood, and a 24-hour urate excretion as well. Another category that occurs in the diagnosis testing process is diagnostic testing. This is when healthcare providers get into the HPRT enzyme activity assays, which we have discussed assays in previous lectures, and proliferation of peripheral blood T lymphocytes. This test is done to monitor for certain components of purines in the blood. And then the fourth and final category of testing for Lesch-Nyhan is molecular genetic testing. The table shown below is for HPRT1 gene only because of the fact that that is the only gene found to be associated with Lesch-Nyhan syndrome. The methods that are utilized in molecular genetic testing for Lesch-Nyhan include sequence analysis and deletion duplication analysis. And as you look to the right of the chart, you'll see the percentage of carrier females impacted by the test and affected males as well. Within modern day medicine, there unfortunately is not a cure for Lesch-Nyhan syndrome. So the treatment for this disease actually only targets these symptoms as they occur. Symptoms and the impact of these symptoms are treated accordingly. For example, gout, which is one of the more commonly occurring symptoms, can be treated using allopurinol, which is a uric acid reducing medication that inhibits the enzyme anthine oxidase. And kidney stones actually are another common symptom that occur with Lesch-Nyhan syndrome and can either be treated with shockwave lithotripsy or also is treated with allopurinol as well. There is not a standard treatment for the neurological symptoms of Lesch-Nyhan syndrome that occur, but medication can be utilized to eliminate anxiety that derives from Lesch-Nyhan syndrome, and behavioral modification techniques can also be utilized to help with the day-to-day behavioral challenges that derive from Lesch-Nyhan syndrome. As for people who are carriers of Lesch-Nyhan syndrome, it is oftentimes recommended that they go and seek out genetic counseling as well, which is a big help to people that are unsure of if it'll impact their children, how the disease is inherited from person to person, and so forth.
So if adenosine is successfully turned into hypoxanthine, it can then proceed along the rest of the de novo pathway, turning into xanthine through xanthine oxidase, and then to uric acid also by xanthine oxidase, and then finally to urine. So this is the extent of the de novo purine synthesis pathway. But what if there was another way to utilize purines? So that is exactly the other portion of the purine pathway, and it's when hypoxanthine and guanine are recycled through that enzyme HGPRT, which I mentioned before. This is called the salvage pathway, turning these two purines into inosine. So in the Lesch-Nyhan syndrome, this salvage cycle is damaged. There's a mutilation in the HPRT1 gene, which leads to the damage of the salvage cycle because there's inadequate amounts to the HPRT enzyme being produced. And this ramps up the de novo pathway, which leads to excess hypoxanthine. Excess hypoxanthine leads to excess uric acid in the blood, or hypouricemia. When there's excess uric acid in the kidney, that leads to hypouricemia. These can cause urate stones, which become urate crystals that lead to tophi, gout, and renal stones. Uric acid also has a correlation with the dopamine neurotransmitter associated with behavior and emotion, which is the tell sign of Lesch Nyhan syndrome of self-mutilation. So in the Lesch Nyhan syndrome, this HPRT enzyme is compromised. But how can we counter that? How can we treat that? We treat that with allopurinol, which blocks xanthine oxidase, which can prevent the hypoxanthine from turning into uric acid. The neurological and behavior issues like self-mutilation are alleviated with anxiety medication. To summarize and bring the picture full circle about these two purine pathways and the association with the two disorders, we have a monophosphate purine getting turned into adenosine, and through adenosine deaminase turning into inosine, and then into hypoxanthine and guanine. This hypoxanthine can be turned into uric acid through xanthine oxidase, and then eventually that uric acid can turn into urine. Or this hypoxanthine and guanine can be recycled back into their monophosphate form. To summarize and bring the picture full circle about these two purine pathways and the association with the two disorders, we have a monophosphate purine getting turned into adenosine, and through adenosine deaminase turning into inosine, and then into hypoxanthine and guanine. This hypoxanthine can be turned into uric acid through xanthine oxidase, and then eventually that uric acid can turn into urine. Or this hypoxanthine and guanine can be recycled back into their monophosphate forms through HGPRT enzyme. On the SID disorder side, the adenosine deaminase enzyme is deficient, which compromises the adaptive immune system. On the Lesch Nyhan disorder, the HPRT1 gene mutilates the HGPRT enzyme, which compromises the salvage cycle, leading to excess uric acid, leading to gout, renal stones, and then also neurological disorders.